Hi, I'm Secretary Walker. Today we had another summit on payer and purchaser perspectives. We talked about ways to collaborate between payers and delivery systems and providers to think about innovative ways to both pay for care and deliver care. It was a great session. We had leaders nationally talk about new models that Delaware could consider. And we also had interesting examples for neighboring states to think about how we can look at the cost of drugs.
So, what's value-based? Whenever we think about transformation at Highmark, we think about the way care is delivered and financed is very critical, and it needs to be transformed. And I know many of you in this room would agree. And if you work with employers, or some of you in the room are from employers, it's very important that we understand how we make sure high-quality care is delivered, but at the right price. And so that's what's important about value-based care. And we have a lot of programs at Highmark, and we're actually have implemented and are working with many provider partners to implement some of those value-based programs. Our goal in value-based programs is, number one, to do what we need to for the customer. So whether that customer is an ACA member purchasing on their own, or it's an employer purchasing like the state for many, many thousands of employees, we think it's important that first we deliver for them. But in doing that, we think the providers have to be successful, right? So it's not just about lowering cost and negotiating lower rates. It's really how do you together change and transform the way care is delivered and financed. So again, that's a very important goal for us. I have a customer that said to me one time, she said, "Why can't it be simpler? Why can't my employees walk into a physician's office and know exactly what they're going to pay?" She said, "When I go to Sears and I look for tires, I see every single tire listed and exactly what the cost is. That's what you need to do around healthcare." Well, those of you in the industry know that it's not that easy.
The one that really is agitating me more and more lately is fee-for-service medicine. Everybody know fee-for-service medicine? You pay each time a doctor does something to you. They give you a test, they operate on you, they write a prescription, they sit and talk to you. They have to do something to you to make a living. Now, I was a journalist for 25 years. And if my editor had said to me, "We're going to do fee-for-service journalism. You're going to get paid by the word. Every time you do something, every time you type a word, you're going to get another nickel." Well, what do you think my stories would have started to look like? Right? Not because I'm a bad person or evil, but I need to work within the system to make a living. So that's how doctors and hospitals today make a living. The only way they get paid is if they do something to you. They don't get paid if you stay healthy and you go to work and you never get sick and you never go to the doctor and you never take a pill and you never get an x-ray and you never get a surgery. They don't make money for keeping us well and healthy. So when you hear buzzwords like pay for value, what we're trying to get at is health and wellness and getting the positive. Yes, we all occasionally get sick and need treatment, and we need to pay for that as well.
I've always believed we can make things better. And, I just feel like maybe we can, but we're not. And I don't know if that's about the politics, if it's about the complexity, but we really need to kind of stand up, work across boundaries. I mean, particularly one of my messages is work with, have partnerships between providers and plans like Highmark does, but you really need to sort of get in there, sit down together, look at that thing popped up again. Just show me how to turn it off before I get to my slides. We really have to do something about this. This is a national emergency. And I don't know if it's our Irish genes, but Cece's fired up, I'm fired up, and Niall is from Ireland, so he's too. So we need to take the energy and do something constructive about what's going on.
And just to give an anecdote, we had a hospital, Doylestown Hospital, spoke at our annual conference this past year because they went from a C to an A on the hospital safety grade. And the CEO said, quite frankly, we were embarrassed by our C. We invested more resources in understanding why we were getting a C. We figured out there were things we could actually do to improve safety that were underlying that C. And we did that. We invested more heavily in safety. We changed the way we staffed the ICU, as an example. And that's what resulted in the A. And you know what? Not only did we get an A, but we're happier, our providers are happier, and we know we're delivering better care as a result. So even if consumers are not using these tools, they're important because we know hospitals and health plans are looking at them, and it's being used to drive change in the healthcare system.
In a wave of innovation, which is being led by purchasers because of the affordability problem. 1850, the proportion of GNP, which healthcare constitutes, is a rounding error. It's approximately 0. 1950, any ideas how much healthcare constituted GNP? Well, it's roughly 4%. 2018, it's approaching 20%. Current trends, respectable economists project, many, that we're looking at 40%. That's a real resource issue. What do we have left to spend on education? What do we have left to spend on infrastructure if healthcare grows by that kind of rate? This is an economic crisis. We're working.
No longer do we want our members rushing to the emergency room or the urgent cares where there is no coordination of benefit, coordination with your doctor. We want the coordination to be with a primary care doctor. We know that primary care doctors can handle probably 80% of the medical needs out there. But right now, their patient panel sizes are just too high, right? So they get my members get 7-minute visits and told to go to a specialist. Or if you can't get into the primary care doctor, go to the urgent care, go to the emergency room. We no longer wanted that product. We wanted a product where primary care doctors are now seeing no more than 1,000 members, right? We are limiting your patient panel size to 1,000. And we're going to take you off the hamster wheel of this fee-for-service where if you only see my member for 7 minutes, well, if you cut it down to 4 minutes and get another patient in there, you can earn more money. That is not the product I want to purchase anymore. I want to purchase a product where my member gets his up to 30-minute visit with a doctor. And I'm willing to pay for that product. I'm willing to pay for it. So here are the parameters. I want my primary care doctors to have 30-minute visits with their people. A visit means a visit. So when they walk in, they're not waiting 2 hours in a waiting room. They're being seen within 5 minutes. I want my primary care doctor to be practicing at the highest level. I want them to be taking the blood of my members. I don't want my members to have to take another day off to run to the blood, to get their blood taken. I don't want them to have to go to the pharmacy that's now closed. I want there to be prescriptions right there. There are certain parameters, we said. And then we put it out to bid, and we said, this is what we want our primary care system to look like. We're willing to pay our doctors a salary. We're willing to pay them a bonus for keeping our members healthy, right?
If you want to learn more, please continue to follow us on choosehealthde.com. We'll also share updates on Twitter at #OurHealthDE. We hope you'll follow along because we're going to have additional summits in the spring and look forward to seeing you there.